Okay, hello everyone. Thank you again for joining us today. My name is Michele L. I'm the CEO of ReelDx. I want to welcome you to our webinar today. We're going to talk about preparing NP students for practice without the strain of off-site clinical placement. Let me take care of just a little bit of business and housekeeping before we get started. We'd like to invite all of you to participate actively in today's session. There's a way to do that by putting your questions into the little Q&A button, see here down at the bottom of the window. If you don't see it at the bottom when you hover over, you maybe exit the full screen view and you should see those controls. Just plug your questions into the Q&A and I will be sharing those questions a bit later with Michele Wolf. With that, let me introduce you to our other panelists today. That is Michele Wolf. Michele is the MSN Program Director at the University of Tampa. She's practiced as an RN for over 30 years and has spent the better part of the last decade working as a family nurse practitioner, specializing in family practice, adult and geriatrics, and acute care. She's currently a nursing instructor and, as I mentioned, the MSN Program Director at the University of Tampa in Florida. Michele has taught courses in clinical management of the adult and the pediatric client. And in addition, she's the clinical coordinator and teaches the MSN clinical practicums for students in adult, geriatric, women's health, and pediatric settings. So today, our agenda, we're going to talk a little bit about the problem at hand of scarcity, have a discussion. Michele and I are going to review some of what she's been doing also at the University of Tampa, and then we're going to open it up for a fully interactive Q&A. And if there's any time, we can talk a little bit more about the use of real patient video in nursing education. So with that, I'm going to say thank you again to Michele for joining me today. Michele, did I cover your background? Is there anything else that okay, terrific. Want to make sure that I have fully covered the extent of your expertise in this area. You and I had gotten into a separate discussion, and so for recognizing that most people who are joining us today certainly understand the problem, but in the event somebody watches this back later, I want to make sure we've sort of level set. You were telling me there's a problem of scarcity in finding preceptor sites, and it's wonderful if you would talk about that a little bit and what you think the origins of that problem are. I would really appreciate it.
So what I discovered is this is a national problem. All programs are dealing with this across the board. Trying to find placements for nurse practitioners, medical students, RNs, it's always a challenge, but the problem that we're going to be discussing today is more what we've done in the MSN program and nurse practitioners getting the experience, nurse practitioner students getting the experience that they need in a clinical setting without maybe having to go into a clinical setting under somebody else out in the community, using your own nurse practitioner faculty to resolve some of the problems we're having that are so time demanding and labor intensive to try to find placements for our students. We're in the process now of hiring a nurse practitioner liaison to actually assist me and another clinical coordinator in finding placements for our students. So just the fact that we have 3 people now working on it, and we're talking placing between 80 and 100 students each semester, spring, summer, and fall, where I know a lot of programs attending today are placing hundreds of students.
How is this impacting your students and I'm going to say their matriculation? Is it causing some kind of backup? How's it really impacting their progression?
So first of all, it's exhausting for them. Ultimately, our program runs that it's their responsibility in order to progress in the program, it's their responsibility to find their own placements. With that said, all 3 of us that I just mentioned in our different roles are working behind the scenes with 2 different programs that we use to keep track of former preceptors, nurse practitioners in the community who have graduated from our program, and we try to use all the resources we possibly can. And then life happens, and then we lose preceptors at the last minute, and that's tears. I mean, literally it brings them to tears. So I think our programs, there's a lot of rigor in all of the programs that we reached out to for this webinar. And I think we would all have to agree it's stressful enough being a grad student and working full-time as a nurse, and then to add these preceptor placements on top of it, and to put them behind a semester is not just their time and the stress. We break them away from their cohort. So, and as nurses, I mean, I'm not gonna skate around it. We are pack animals. So they're in their packs and they want to stay in their packs, and they're in an uncomfortable situation transitioning from an expert RN into a novice nurse practitioner. So we want to give them the entire toolkit that they need to be confident, safe, and successful as nurse practitioners. So I feel like it's always shooting, as hard as we work to make this happen for our students, as educators, it's really shooting ourselves in the foot not to be able to provide a good quality preceptor placement for them without the struggle. We certainly get the placements, and we'll only put them in quality settings with quality providers that give quality care, but at the same time, they're getting harder and harder and requiring more resources to find.
And that was, if I can put a few words in your mouth, part of how you landed on ReelDx, right?
Yes.
This was the challenge you were facing, and that's really how we met, because you had been looking for a way to introduce quality scenarios into simulation, because you were struggling to some extent with the preceptor sites and making sure students had the, I'm going to say, appropriate amount of clinical training. Is that fair?
That is fair. That is fair. So what we're trying to do now, and what we have done in the past several semesters, is we've started to incorporate the use of ReelDx in a simulation setting. So taking students into a simulation setting to give them adjunctive clinical hours has always been a thing in most programs, but supplementing their hours is one thing. Actually substituting hours is something that we're looking at. Currently, we require 224 hours per practicum, which nationally, that's a pretty high expectation. Normally, what I found is it's between 160 to 200 hours are what most programs are requiring. Well, with that said, that's still a lot of time trying to find preceptor sites for our students. So what we started doing initially until this semester is we started taking students that were having difficult times in the clinical setting. They were having problems. They were struggling in health assessment to synthesize content that they were learning in the didactic into the clinical setting. So we used it almost as a form of remediation. Then we moved from the remediation into actually taking them into the simulation lab and allowing them to run through scenarios. And that was always a challenge because it was so labor intensive for everyone out there. And I'm sure almost everyone in the audience has built a simulation for students, and it's very time consuming. It takes a lot of manpower to run it. Then there's the debriefing, which is certainly one of the most valuable aspects of the entire simulation. So bringing ReelDx in, that was the solution to decreasing the manpower required to run a sim. And basically, we have an entire section of our simulation lab set up into 6 exam rooms. We put ReelDx, which is a 2 to 3 minute video, up, and that sim man no longer requires all of this high tech. It can just be a mannequin lying there. You can certainly use high fidelity mannequins to run this, which we do for checkouts and things like that, more high stake type of test outs with our students. But for the most part, they can go into the room, they can examine the patients based on what they're seeing on these ReelDx clips. The other thing we tried to do is using real live patients and bringing in like people from our dance and acting program here at the University of Tampa. And that was a lot of fun, but again, required a lot of hours and manpower and resources. So they had makeup and showers and a place to change to do the moulage.
Yeah.
So that also, with ReelDx, your real patients are right there. Boom, you put them up on the screen, you have the TVs going, and the students are in the rooms, in and out, just like they would if they were following me as a preceptor in the clinical setting.
Well, you were nice enough to have a member of your, I don't know if, I think you had a student actually capture
Yes.
some footage of all of that happening. So what I'm going to do is I'm going to share a video that is, we had done as a customer spotlight video, and I will certainly make the link available to anyone attending today who wants to see the full length video and interview. But if I can, Michelle, what I'm going to do is share the video and ask you just to tell everyone what they're seeing, because I'm not going to share the actual audio of us talking about it.
So what always makes me laugh with our students is that when they come into a room, even if it's the lab, they always want to sit down. And those chairs literally were there for students to sit in the chairs, not sit in the chairs, but for the people setting up for a simulation for the BSNs later in the day.
Right.
They were literally going to sit down and they wanted to watch us. They wanted to, sit there. I'm like, no, everyone stand up. And it's just amazing. First of all, they're all nurses, just like everyone else's students are. And once you get them up and hands-on, it's just a whole different learning environment than sitting in a classroom at a desk with a computer in front of them. They're more engaged. They make better mistakes, if you will. And they learn from those mistakes. We just ran one similar to this one that we're watching here, which was a couple years ago now. And the students are assigned to the simulation areas, and then they just start rounding to see patients. And you can see the look in their face. They look a little terrified, like, is she kidding me? We're going to start seeing these patients. So then as we move forward into this, they're passing information back. They're trying to make their teams, they're getting a little bit more concerned about what they're going to need to do. But once we get into it, they're really engaged. We pull the video up. We just ran this last week in the simulation lab, and it's always fascinating to watch them. And I apologize about the bumping with the video camera. I actually paid a student from a previous semester, one of the BSNs, to film this, and I was hoping to avoid the type of movement in the film. But anyway, this gentleman comes in, and what we've done is he's got a respiratory infection. So they see the video, and then they have a mannequin, one of the simulation mannequins, and they go over to assess the patient. And the mannequin's been made to have the same complaints that this gentleman has, who's from an assisted living facility, who is with his son. He has some real end-of-life concerns. The students have to decide, are they going to admit this guy, or are they going to send him home? And if the son wants to take him home and it's against medical advice, then what do they do then in a primary care setting, an acute setting? They have tools with them that they know to use on their phone. They've got Hippocrates. They have UpToDate. They should have, and most of them in the lab last week did, they were able to use the CURB 65 to decide evidence-based, should they admit this patient or not. We've got a film the film is actually provided in ReelDx. As they open and scroll down, it will provide all the clinical findings, which is locked for the students in this video. And we put the chest x-ray up there, but they don't have access to any of the information, not vital signs, not labs. They have to know what to ask. They have to know how to assess the patient. We run this as a group at first because you could see how terrified they were. And we feed into them a little bit with their pack mentality and allow them to go through it as a pack. But then by the end of the semester, they're rounding, and they're rounding seriously. In the hallway, they bump into one another and they're like, oh, excuse me. They grab the next chart, they open the door, they go into the room, they see the patient, they're engaged. And they're learning what we should have asked. What were the pertinent negatives? What were the pertinent findings? What did she ask? What should I have known to ask? And now they get to form it as a group, and they use each other's knowledge to decide what they want to do. And then there's heated debate. Half of this group actually wanted to admit him. The other half decided that they were okay with sending him home because the son keeps pushing to send him home. So it's interesting to see that too, because they're also learning, go by your evidence-based. It's not appropriate to send this old gentleman with all these comorbidities with a pneumonia that he's had a month ago, and then we don't know if this is a reoccurrence or he never recovered the first time. So, and there were two of them that were actually felt pushed by the son to release this gentleman back to the assisted living facility, which is a great learning experience. When they sit down together like this, they can talk about it, they can hash it out, they learn to have heated but polite and respectful conversations, which sometimes they need coaching with that because it can get a little ugly, but that's fun too. It's fun for us, it's fun for them. You always have that strong student, whether they're right or wrong. They come in with such force that the rest of the group is like, whoa. So they learn to deal with that personality too, because you have family members like that. And the ones that backed off and moved away from the evidence-based practice and allowed that gentleman to go home, hopefully they're never going to do that in the clinical setting. Because after all of this happens, you can see they go back in, they're like, hey, we actually did a great history on this guy, but we never really listened to him. So they realize, you know what, the patient's still here, let's go back and fix this. And they go back after they realize, writing their SOAP note and formulating their plan, that they actually have no vitals and never really listened to him. So it's just such a great learning experience across the board. And I didn't have to go out to the community and find patients, bring them in, pay them. This is part of their subscription that they buy into. And then we go, you can see them now, they're so engaged in this and they're actually proud of the way they've come up with their plan of treatment. And it's so interesting to see how many variations they come up with, some completely right and just different variations, and some just absolutely wrong. And they will have heated discussions, and it's so funny to hear them throwing guidelines around. It really promotes that type of discussion. And then when we show the actual differentials for ReelDx, they'll turn around and say, oh, we thought of that. Well, you didn't call it, you didn't rule it in or out. You have to be more assertive about it. So it's just really nice to be able to have this information and the debriefing. Like I said earlier, it's just such an integral part of this entire process. And ReelDx just has made it so easy for us because we have real patients on hand 24/7.
Right. I'm going to stop the sharing of the video and just remind everyone, if you have questions that you'd like to ask me, or questions obviously for Michele Wolf, please put them into the Q&A. You hover at the bottom of the window, and I will happily pass those questions. Michele, please tell us, how has this adjustment or changing the way you're delivering this, how has that impacted your students? What's been the outcomes that you're seeing with your students as a result?
So our students love it. It depends what we're using it for. If we're using it for remediation, it's just unbelievable. Like, to me, as a nurse practitioner and a nurse for 30 years, the educator part just is new for me. It's only 5 years. And it's so rewarding to me to see their faces when they have that aha moment, which now they're ready to go into clinical. And what's really funny is I always tell them, no one knows you're here. This is private. Your preceptor doesn't know you're here. Let's fix the problems that you're having. Even I did women's health with a student the other day. I don't know what the problem was, but for whatever reason, she became literally a nervous wreck about having to do a pelvic exam and just kept falling apart. So she has not completed a pelvic exam. So I took her down and we were able to do 7 pelvic exams. And then she went into clinical, and her instructor called me yesterday, as a matter of fact, last night, and was like, I don't know what you did with her, but whatever it is, she's a different person. So it's just really nice. So the remediation part is just a great use of ReelDx. Another great use of ReelDx is to give them all.
Michele, we lost your audio. There we go.
Sorry, it muted me for some reason. Maybe I'm talking too much.
No.
But anyway, we give them additional clinical hours now. And what we're hoping to do, and this is the plan right now, I've already gotten it through curriculum, is we are actually going to give them just 24 hours less of clinical. We're going to require 200, and then the other 24 is going to be in the simulation labs using ReelDx. So we're going to provide that experience for them, because on our class course surveys, we're not just using this in our practicums, our clinical management courses, we're also using this in our didactic courses. And we're starting to use it across the board. At first, it was just clinical management of adults, older adults, and pediatrics. Now we're starting to use it in health assessment, patho, pharmacology, and it's just been phenomenal. The more we use it, the better the feedback becomes from our students. And in addition to that, there are surveys for our faculty are reflecting much happier students. And what we're finding in this cohort that we started using ReelDx, there are ones starting clinical or started in the spring this semester. They are absolutely, this cohort is much stronger clinically. We've had far less problems, which again, that saves faculty time as well. If you're not constantly doing remediation, if you're not constantly dealing, with now it's a few students. Before it was a percentage of students. And it's a lot of wear and tear, as everyone knows on faculty, how limited faculty is in nursing programs, especially at the MSN level. It's just really nice to have kind of a second hand, if you will, a helping hand with ReelDx. And what I've done is I've broken up cases into all the different directed courses. So for every core course in an MSN program, I've broken down so that every I almost said provider, but every instructor in the program has at least 5 to 10 cases that they can just take into their course and put up and use. And the nice thing about ReelDx is if you don't have a course plan, you play a 2 to 3 minute video, and then it's a reverse classroom. You have them back and forth, engage, talking about evidence-based, talking about plan of treatment, talking about differentials. It's just a great way to open up clinical dialogue. And you can see them. They're telling me, I don't get this. I don't get this. Well, yes, you do get it, because I'm hearing your conversations in the case of the day with ReelDx every week that we meet, and I'm seeing your exam scores and they're going up. So it is coming together. And sometimes at the first semester, they don't realize that, but we're seeing that it is coming together, and ReelDx is really helping a lot of them, and they're verbalizing that it's helping a lot of them to be able to synthesize all of this content into practice.
Well, I'm certainly, of course, as you can imagine, heartwarmed and thrilled to hear that it's having such a great impact in your program with your students. So let's take some of the questions. One person asked, to clarify, is the patient a paid standardized patient? And I think that was maybe more directed towards me. I'm assuming you're not paying any of your students who you do with Moulage or, okay.
Oh, no, they had a group that they were contracting to come in and do the Moulage.
Oh, they did. So you were paying the students
Yes. So we did have to, that did come out of our budget. We did do that, but we don't do that anymore. ReelDx has eliminated that 100%, the need to do that.
Right. And we don't pay the patients, or for anyone who's asking about ReelDx, we don't pay either the patients, obviously, or the providers, because we feel that that's an ethical conflict to ask a provider to then effectively, you could argue, pressure a patient to participate. So everyone who creates content for ReelDx and all of the patients are doing so on a voluntary basis. I did have somebody mention you must have a face-to-face program rather than an online program. And I'm actually finding we've got another program, Olivet Nazarene University, uses our cases in just this same way, only they do all the interactivity with the students through LMS chat functionality. Have you had any experience with that with your students using ReelDx in an online scenario?
So this is really exciting. We have our very first, we're starting our DMP program in the fall. So that is completely online. But back at the MSN level, we have our first hybrid course this summer. And it's the role of the nurse practitioner. And using these cases, it's amazing what we can come up with. That gentleman that we just saw in the simulation video that you showed, that is a perfect example of somebody where the role of the nurse practitioner, where DNR, maybe sending him home and putting him on hospice, talking about end-of-life issues with the son and family, where we're looking at curb criteria, we're treating him according to evidence-based, he has to get admitted to the hospital. One group came up with all of that. So we're really excited to incorporate it this summer into the hybrid course. And we have 6 cases because summer's shortened for us. It's 12 weeks. So every 2 weeks, there's a case being introduced for whatever the topic is for the role, teaching them the role of the nurse practitioner. So we're really excited about that.
Which leads to one of the other questions. Gwen asks how many family nurse practitioner cases are in ReelDx, and I'm going to let you answer that question because my response tends to be our cases can be used across a spectrum. We have EMTBs all the way through DNP students using them, but perhaps with your expertise, Michelle, tell folks what you think as far as how many nurse practitioner cases you might find in ReelDx.
So I ended up going through a lot of the cases on ReelDx, and one of the reasons I did this was because I had a faculty member and he just absolutely was so resistant. You know, we called him the hater of ReelDx because he just hated it. And now he is so funny. He is the first one to go down into the sim lab or to bring it into his classroom, and he teaches older adult. It can be used. There are a lot of pediatric cases, but what I did for our faculty, just to show them how it can be used, is I broke it down into adult, older adult, and pediatrics and women, and then all the core courses. And then I looked at how many cases and what were the top 3 to 5 cases to incorporate if you did nothing else into your courses. So there are a lot of family. We're adult Jerry program. We have an adult Jerry track, and we have a family track. And most of our students, I would say we graduate 20 to 30 a semester, 25 to 30 a semester. And of those, there's only 2 to 5 that are adult Jerry. The rest of them are family. So most of our nurse practitioner faculty are family. I think we have 1 PNP and we have 1 adult Jerry. But we're all family, and we have these videos literally can be done across the lifespan from crib to crypt. I mean, really covers everything.
I've not heard crib to crypt before like that.
Sorry.
Yeah, it's all right. We have, in the longer answer is ReelDx's library is currently over 700 cases. There's probably over 1,000 diagnoses, and several hundred of those cases are certainly in the what I would call a FNP track, and could.
So I have to say one more thing, Julia. So this, my ReelDx hater, I want you to know that he is taking a group with another nurse practitioner faculty to Ghana this summer. And I wanted you, next time I'm going to film him behind his back and show it for our next webinar. You should have seen him getting the BSNs and MSNs ready using the World Health that's on ReelDx, trying to get them prepared for what they're going to see in a country like Ghana. Right. And when they go to the Dominican Republic, they use the ReelDx videos as well. So it's just, I mean, it really can be used everywhere. And it's just super exciting to see somebody that's so resistant, so excited. I mean, I spoon-fed him 3 cases for his seminar with his world travelers this summer. And he's like, oh, but what about this one? Look at this one. Right. This one's incredible. And I mean, that's how the students are with it too. And we assign them their very first semester in health assessment. They have to look at and open drawers on 10 cases. And they're like, oh, one more thing to check off so I get the grade. And they get in there, and I get all of these emails, and we get all this feedback in class about how much they enjoy it. And then when I go look behind the scenes at the spreadsheet to make sure everybody's done the 10 cases, they've done 20, 30 cases, and some of them continue to do it until their entire prescription, even after they are subscription, not prescription, subscription expires even after they graduate. So they really do enjoy doing it. It's fun for them. It's interactive, and it's challenging, and it's a great way to prepare for boards as well.
We've had several people ask about specifics on the clinical hours again, so I'm gonna ask you to rewind a little bit. So the questions that are can simulation count as clinical hours, or do you give clinical hour credits for those sessions? And then I've had certainly another person say, does your board of nursing in your state accept the simulation time as clinical hours towards graduation? So we've had 3 or 4 folks essentially ask similar questions and want to know if the simulation and ReelDx hours count towards the total practicum hours, and then how many total practicum hours are required in your program. So if you would just review all of that for everyone, I think it would be helpful.
Sure. So I've been looking into that a lot, of course. I actually just started looking at that in the winter, over winter break, and that's when I reached out to a lot of people today to find out what they were doing about this preceptor crunch and how many hours their programs were doing. And the bottom line is you have to have the number of hours that CCNE, if you're CCNE certified or ASIN certified, those are the 2 certification bodies for our programs. So depending on your certification, you have to meet live hours with a preceptor in a clinical site, is the answer that I got from both the CCNE and from ASIN. So with that said, we have not reduced our hours, but before, when I mentioned we're doing 224, we're way above the minimum required, which I don't want to say off the top of my head. Off the top of my head, I don't want to be quoted on this. I think it's around 180. So as long as you meet whatever the set number is to keep your accreditation, but one of the things when you reduce the numbers, we have almost 100% board pass rate on both the ANCC and the AANP. One of the things we think contributes to that is our 224 hours that we require our students to do. So we don't want to decrease our hours because of the preceptor crunch. So what we want to do is still give them quality clinical hours, and we do that as a supplement. We give them the ReelDx. So are we going to eventually move down to the requirements? I think we're going to have to. I think we are going to have to put less of a burden on our providers that precept and on our students and on our faculty that's trying to find preceptors.
Right. Yeah, it's for us at ReelDx, we've made trying to introduce the patient into the classroom, really has been the mission of our organization since we started back when. And many folks started with sort of that sage on the stage, just broadcast the content in class. But the more I work with other educators, the greater the number of use cases that we're starting to see come up. And, I've had a couple of programs ask about our, that world health population, in terms of using it for like a health assessment course. What would be your, I'm going to say your recommendation to other programs that might be considering this solution? How do we help them be more successful right out of the gate, right? One of the things you did was all that heavy lifting, helping your faculty identify content, and you've been kind enough to share that with us, and we're going to be building that into the ReelDx product so that you can see the cases, I'm going to say maybe better curated for an NP core curriculum. That all said, I wonder if you wouldn't mind sharing some of the other ways you're using it. You've talked about, I know that you do soap notes in class, you have students work in small groups. Would you mind talking about some of the other use cases besides the simulation?
Absolutely. So one of the things that we do, and I laughed when you started to mention this because I have a student that I had in a previous class, and she's always late, but we just moved into a new building and parking is terrible right now because they're working on the garage. So she's been on time every single day, and last week she showed up late and she came flying into the classroom and she's like, did I miss the case of the day? Meaning ReelDx, because no one wants to miss that 2 minutes because they know I'm not going to play it again. So they are it's great to do in the classroom because it doesn't take up a lot of class time. We just used it the other day for the health assessment class because they are doing their final soap notes for their exit part of their clinical checkoffs because they'll be starting clinical in the summer. So they were formulating their soap notes, and they basically formulate the soap note based on that 2-minute clip. And they're able to put on their questions that you would have asked, and you can see them all writing old carts on the thing to get all of their information for their points. And just now when I went in to prepare for meeting with you all today, I took my papers off the printer, and I saw the case of the day today and what number it was on ReelDx for the older adult clinical management. So it's just easy to do. We sometimes will divide them into groups, and we'll give them all a different case, and we give them 10 minutes to prepare for the case, and then their group has 10 minutes to present the case. And they just love those cases. You know, they're on their computers, they're in small groups of 2 or 3, and it's just like them in the sim lab, but we use it in the classroom. So when I do the guidelines and when I discuss respiratory, was a lecture that I did at the beginning of the semester, I will give them that patient at the end, and I give them a patient at the beginning. At the beginning, they're looking at me like, I'm never going to learn all this stuff I read. I thought I was prepared. I'm not getting it. Then I present the content, and then I give them that patient either at the end or the beginning the following week. And it's amazing to see them struggle through, because they're not at the clinical portion. They're just learning the management. They're not in the practicums yet. It's amazing to see them struggle through, but being able to hit diagnoses and treatment plans. So it's really just brought them past repeating patho, repeating health assessment. Again, it's synthesizing what they've already learned in those core courses into the clinical setting. So when we're doing clinical management, we can actually bring that into the classroom. And we can use pre and post ReelDx cases, taking 3 minutes apiece to look at pre-knowledge and post-knowledge. You also know who's prepared for class. And usually it's the ones that struggle with that 2-minute ReelDx at the beginning that are also struggling on your exams. And you know they're not reading. You know they're not putting the time they need for whatever reason into being successful. So it's actually a great way to evaluate and come up with remediation plans for your students.
Well, we are nearing 40 minutes past, and so I'm going to make a last call for questions, and with the plan that we're going to wrap up here in the next 3 or 4 minutes. I did get a few folks who've asked me about pricing on ReelDx. Rather than getting into any of those details, I will just tell you it's a institutional license along with a per head count cost for faculty and a per head count cost for students. Obviously, there's a sliding scale depending on program size, and you can either have students purchase it like buying a textbook, or your program can prepay for their licenses. And some programs choose to they buy a batch of licenses and assign them and reassign them. It's really, we try to also adjust the subscription periods based on working with programs. We know some folks use it contiguously for 16 months, others need a year, some need 2. So we recognize that flexibility is important for our educators to be able to craft the use of the ReelDx content. So my last question to you, Michele, is any advice for anyone who's considering incorporating ReelDx into simulation, into their program? Any advice you'd like to offer?
You know, my biggest advice is, being a director, it's always challenging for people who don't want change, your faculty that doesn't want to embrace change or learn new technology. And this, is so useful, and it really requires no training. It's just effortless. It's intuitive. You show them, they get on and play around with it for a few minutes, and they're able to use it. Every single one of them, I was willing to go in the classroom. Some of them took me up on that, just to get it up and running and make sure they could work it. But now it literally took me probably a total of 1 hour over the course of that first semester to get everybody up and running. And then it just runs itself. So I think when you look at the cost, and you look at the cost of other things out there that are very high tech, hard to use, and a lot of times, unfortunately, just sit on the shelves because faculty doesn't want to, or doesn't have the time. I don't want to say they don't want to take the time. They just don't have the time to put into this. So I would just say go for it. Give it a try. I think once you give it a try, people just will love it. Even your resistors will come around.
Well, thank you, Michele, again, for joining me today. I really appreciate it. I thank everyone who's joined us today. We absolutely will send links to the recording of today's session. If you have questions about ReelDx, feel free to email me directly, julia@realdx.com. Michelle, do you mind sharing your email address with folks who might have
Sure.
questions for you?
Absolutely, yes. Feel free to email me. A lot of people do already have my email, but it's M as in Mary, Wolf, just like the animal, WOLF, at UT for University of Tampa .edu.
Terrific. Michelle, thank you again for joining today. Thank you everyone who attended, and I'm looking forward to our next session. Have a great day.
You too. Thank you.
Bye-bye.
Bye-bye.